Good afternoon, everyone. My name is Amanda. I am a registered nurse by profession. I am part of the CHP-NET Christian Health Professionals Network, and we are excited for our first anniversary and also celebrating World Sickle Cell Day 2022. It is an exciting time for Christian healthcare professionals and also for our communities. We have decided to share some informative, educative sessions on diseases and illnesses that affect our communities. I am here to share with you my knowledge and experiences living and working with people with sickle cell disease. As part of CHP Network education sessions, we are delighted to have this session. What is sickle cell disease? Sickle cell disease is a group of hematology disorders under the umbrella of hemoglobinopathies. It is a hereditary or genetic disorder which alters the structure of hemoglobin, which results in reduced oxygen carrying capacity blood to tissues and its organs. There are different types of hemoglobinopathies, so thalassemia, G6PD, and we are looking at the topic of sickle cell disease. Sickle cell disease affects the erythrocytes, red blood cells, that becomes crescent shape, hard and sticky. The history of sickle cell disease. The original mutation was of West African lineage, where it has the highest prevalence in Ghana, Sierra Leone, Nigeria, and other surrounding countries of high population. Some other countries include those of the Mediterranean, Sub-Saharan, India, the Caribbean, and more of the malarial areas of the world. The diagnosis of sickle cell disease is by genetic testing. It is often mandated prior to marriages in some communities to ensure that the disease isn't passed on. There is genetic counseling through amniocentesis, usually done in the first trimester, and through CVS, chronic villus sampling. Other testing is done in adults through a blood test which is drawn from the veins, and lab testing called electrophoresis is done to determine the genotype of the hemoglobinopathy. Hemoglobinopathy present. It is part of the newborn screening in all babies in the UK, also called the heel prick test. And this would be offered to parents who decline the genetic testing during antenatal visits. Types of hemoglobin and sickle cell disease. Hemoglobin SS, most common type of sickle cell disease, inherited with one sickle gene from each parent. This is regarded as the most severe of the disease. Hemoglobin SC, or sickle cell C disease. It is inherited from one sickle gene from one parent and one C gene from the other parent. The patients with SC has similar symptoms to type SS, but less anemia. Then there are HSB positive sickle cell beta thalassemia, where the sickle cell gene produces crescent-shaped red blood cells that breaks down, while thalassemia produces smaller red blood cells. There are two types of beta thalassemias. Sickle beta thalassemia is mild, while sickle beta 0 thalassemia is a severe form of sickle cell disease. Then you have sickle cell hemoglobin SD, SE, and SO. And this is where it is inherited from one sickle cell gene and another hemoglobin gene, D, E, or O. More rare, but the severity of these varies. The genetics of sickle cell disease. There will be both parents, father and mother, with a trait and no genetic component, and where the children can have traits or no genetic component. If both parents have the trait, there is 1 in 4 chance of the child having sickle cell disease. If both parents have the genetic composition, i.e. sickle cell disease, both parents having sickle cell disease, the likelihood is a 4 in 4 chance. A parent with sickle cell trait can also exhibit symptoms of the disease depending on the trait. The structure of sickle cell disease. When sickle cell hemoglobin HbS gives up its oxygen to the tissues and organs, it sticks together, forming long rods. Because it becomes rigid, inflexible, and sickle shape, it is unable to squeeze through small blood vessels, causing blockages and often reduced oxygenation. Unaffected red blood cells has a lifespan of 90 to 120 days. Affected blood cells, sickle cell blood cells, has a lifespan of 10 to 20 days. The clinical presentation of sickle cell disease. What we term crises, very painful, very uncomfortable, and very debilitating. There would be an anemia present, dactylitis or osteomyelitis, which are considered swollen legs and fingers, toes, hands, and can be confused with a crisis, or it can be part of a crisis. Frequent infections, acute chest syndrome, delayed growth, vision problems, infertility to both genders, priapism, which is a very painful penile it's a painful penile erection, and it's considered a medical emergency. An enlarged spleen, if the spleen is present, renal disease, and avascular necrosis. The clinical presentation for patients can vary, but often include fever, jaundice, pains, chronic and acute, clubbing of the digits, so the fingers and toes, blotchy skin or nail beds, abdominal swelling, and urine infections. Complications of sickle cell disease includes but does not exclude stroke, early onset menopause, blindness, leg ulcers, gallstones, pulmonary hypertension, hypotension, organ damage, priapism, complicated pregnancies, and mental health issues. The holistic effects of sickle cell disease include, but may not all present, tiredness, apathy, mood swings, constant hibernation or reclusiveness, reduced appetite, extreme eating, either or, unable to complete activities of daily living, bathing, cooking, cleaning, etc. Lack of faith or self-esteem, financial struggles and consistent complications in employment, changes to the weather, so the extreme weather, be it hot or cold, stress or worry, breakdown in relationships and support systems, lack of consistent advocacy, intimacy, mental health issues, and fear of blindness, permanent disability, or even death. Management of sickle cell disease. I liked the use of the EMAS stop, look and learn, red, yellow, green traffic light system that they have. So when you stop the acute sickle cell crisis is when the sickling of the blood cells blocks the vessels, causing damage. This can result in vaso-occlusive crises, which causes pains and organ ischemia or infections. If missed, this can lead to lifelong disabilities, including death. In the emergency department, the main goal is to present complications of sickle cell crises with urgency. It is imperative to achieve effective pain control by starting analgesia within the first half an hour of hospitalization. That's the stop. Look at the complications: acute chest syndrome, abdominal crises, stroke, avascular necrosis, in men, priapism, and aplastic crises, infections, parvovirus, any sort of limiting presentation. And the learn includes refer to the treatment hospital for guidance. So if it's like a district general hospital or an urgent care center, find out from the patient or their carer or their relatives, where is the treatment center and what is the appropriate care plan? Does the patient need oxygen? Does the patient need analgesia? Does the patient need increased fluid intake, be it oral or intravenous? Consider intravenous antibiotics if suspecting an underlying infection. which can also trigger a crisis. Keep the patient warm but not hot and not cold. And refer to your hematologist or your hematology team. Hydration is important. Oxygenation, prompt and adequate analgesia, early treatment and management of infection, identify, treat, and escalate any complications. I'd like to dispel some myths regarding the management of sickle cell crises. Patients are drug seeking, first and foremost. This is very dear to my heart because if a patient comes in with a headache, migraines, nausea, without a sickle cell crisis, you would treat that patient regardless of presentation. However, there is a mindset that patients are presenting with a sickle cell crisis because they are drug seeking. Efforts should be made to limit opioids, but not excluded. Patients may look comfortable or quiet in the department, and not every patient rides around with pain or screaming, I'm in pain, I need pain relief. I can only talk for my experiences. I actually become reclusive and I sleep. I don't want to talk. I may watch TV or concentrate on my phone because I don't want to be deemed as a nuisance or disruptive. And many patients feel that way because of inexperienced or healthcare professionals not understanding the urgency for analgesia. As I always say, if I have presented in an emergency department or an urgent care setting in crisis, that means I have exhausted all of my home medication, all of my home management that has been discussed with my tertiary care providers. The treatment of sickle cell disease and the management of sickle cell disease includes analgesia. So it can be paracetamol, oral, codeine, morphine intravenous, oral, subcutaneous, intramuscular, and even through enemas, so Voltarol enemas, codeine enemas. Antibiotics, often patients are on prophylactic antibiotics. Therefore, when presented to an emergency or an urgent care setting, consider stronger antibiotics, be it oral or intravenous. Vitamins, folic acid, ferrous sulfate, vitamin B12, your vitamin D levels. Obviously, living in the UK, we probably have about 10 days of proper sunshine. So always consider those things in terms of their nutrition and vitamins. Hydration is really important. You know, we are always drummed into our heads, keep hydrated. So if we've come into an emergency room or a urgent care setting and has signs and symptoms of dehydration, consider escalating to intravenous fluids if and where necessary. So hydroxycarbamide, hydroxyurea, it is a cytotoxic group of medications that requires close monitoring and prescribing by specialists. And this is a novel treatment pathway for patients who are trying to avoid routine exchange transfusions or top-up transfusions, and this helps reduce crises and reduces the need for blood transfusions. Blood transfusions, and this is where I talk a bit more on blood transfusions, and I implore and ask and plead and beg the BME communities, African mixed heritage communities, to give blood, to be on a donor register for bone marrow and blood transfusion, as it is a closer genetic makeup for patients with sickle cell disease and thalassemia. And having blood transfusions are an integral part of our survival. It's an integral part of improving our health and the management of crises and the management of our daily living. So there are two types of blood transfusions: exchange transfusions. It is a more extensive transfusion where it is an automated on a machine where donated blood is filtered and transfused whilst removing and reducing the sickle cell blood cells in our bodies. And yes, it is very time consuming for both the healthcare professionals to arrange and administer this, but it's also very much time consuming for the patient, because oftentimes it's not a same day treatment plan. The patient may have to go for pre-blood tests, cross-matching, group and save, if they've got antibodies, if they've got reactions to or previous reactions to blood transfusions, then the cross-matching and the planning of it is even more extensive. Then we have the second type of blood transfusion, which is a regular transfusion, and we often call these top-up transfusions, where there is an anemia or low hemoglobin with mild or very urgent management, or places where there isn't an automated exchange transfusion service. This is something that healthcare professionals need to look at and get the support from hematology in doing so. Patients that are on recurrent exchange transfusions and regular top-up transfusions have to be monitored for iron overload, and where there is iron overload, there would be a need for iron chelation, which is also another medical intervention, another medical management for patients with sickle cell disease. Bone marrow transplant, and we're hearing a lot more of this, especially in pediatrics and young adults, where there are gene therapies and bone marrow transplant services that are fighting and trying innovatively to get more people of BME backgrounds to be on the bone marrow register. And if you need any support in getting registered, you can go on the National Health Service Blood and Transplant Services on their website, and that can direct you to the location, the best possible location, and you can either register online or telephone call and get that support. So the treatment and management of sickle cell disease continues in terms of vaccinations. Childhood vaccinations are very important. The hepatitis group vaccinations are very important, especially for patients that are having recurrent blood transfusions and exchange transfusions. Pneumococcal and flu vaccinations are very important for our group of people. And obviously the newest vaccination is the COVID-19 vaccination, whichever one that is applicable to the patient, because we are deemed as clinically extremely vulnerable groups of people. Other investigations for sickle cell disease and in the management of a patient with sickle cell disease include frequent blood tests, liver function, renal function, hemoglobin F percent, so that's the fetal hemoglobin percentage that is being monitored, platelet count, reticulocyte count, white cell count. We have annual eye tests to exclude sickle cell retinopathy, and as I said in previous slides, blindness and eye complications do occur. Lung function tests, cardiology, ECGs, sexual health screens, and blood tests for viral blood-borne diseases and viruses. Psychology is so important. Your mental health, living with a long-term hereditary condition that causes pain, causes anxiety, causes any sort of change to your mental health. I always advocate that such patients, be it children or adults, teenagers, should have some sort of psychology input, some mental health awareness input. It's really important because it can be debilitating both physically and mentally. Dental care and orthopedics are, and because sickle cell disease is all-encompassing within your whole body, it's really important that you get the healthcare professionals involved. It's multi-organ, it's multi-faceted. In pregnancies, the monitoring is even higher for women with sickle cell disease because of the risk of early miscarriage or late miscarriage. Obviously, having the genetic makeup to either have a trait baby or a patient with, or a baby with hemoglobin SS or hemoglobin SC. The psychology and the multidisciplinary approach is so important with patients with sickle cell disease. I like to talk about inequalities to sickle cell disease. Obviously, there is a notion that it's only a black illness, it's a black disease, it's a black issue. It actually isn't. It's everybody's issue. And there are racial inequalities to the disease. And within services and within the NHS, sickle cell disease does not generate an income, for instance, in terms of research and fundraising and things like that. So it is often deemed as like a drain to services, but actually having this disease does not exclude us from getting the appropriate care and treatment with empathy, compassion, research, and professionalism. The inequalities include standardized care and access to good care in regards to, let's say, a patient who has cancer or drug addiction or a sexual health condition. The disparity is very obvious, it's very open, and it's very true oftentimes. Access to community services are prevalent or it's better or improved in areas that are inner city compared to those that are in the shires or where there isn't a high prevalence of BME populations. The socioeconomic inequality or deprivation is very high risk, and it is a recurrent discussion, and due to the high attendance of sickness and the high prevalence of sickness due to hospital admissions and higher comorbidities. It's very, very true. There is a big gap in research compared to other hereditary diseases like lupus, cystic fibrosis, MS. And this is due to patients, families, and carers' involvement. Although it's being improved within the Sickle Cell Society UK and other international corporations in the last sort of 2 to 5 years, there's a more humanistic approach to sickle cell disease and research. And obviously the pandemic of 2020 has really highlighted the inequalities to sickle cell disease and the employable opportunities that are available. And when we're talking about employment opportunities, it's because of our high prevalence of sickness and being in pain and, and every other thing that was mentioned in previous slides. But if there is a compassionate employer, or an employer who understands, and oftentimes I say to sickle cell colleagues like myself, being open and honest can get you very far with the disease. Being open and honest with yourself, being open and honest with your employers, being open and honest with your communities to support you. And when I discussed the myth in regards to sickle cell patients and sickle cell parents and loved ones and relatives, we are very resourceful, we are very much hardworking, we are very much educated. But because of the nature of the disease, where it's an uncertain disease, and makes it harder for long-term employability. And we need to get that right. We need to get advocates in employment, in networks, in areas where we are heard and listened. So, in terms of thoughts and feelings around sickle cell disease warriors, sickle cell warriors, it is to normalize talking about mental health within the sickle cell disease. Getting healthcare professionals to be empathetic, to be reasonable, to be compassionate to us, and getting it right for us. Oftentimes you get the phrase used, oh, but you don't look like you've got sickle cell, or you're a sickler. I don't like that word because I'm not a sickler. A sickler is a garden tool that you use to remove weeds and things. No, I am not a sickler. We are not sicklers. And I ask relatives and friends and families not to use that word because there is a negative connotation to it, attached to it. We are human, we are a person, and we want to be looked at. You don't say someone's got cancer, so they're a cancerer or whatever. You say that they're a cancer survivor. Yes, we are a sickle cell survivor, or we're sickle cell warriors, and that's what we are. Okay? we are not the same. Not every sickle cell patient or sickle cell warrior is the same. Everybody has a different journey. Everybody has a different care need. Everybody has a different way of managing the disease and managing their pain, managing their medications, managing their work-life balance, and things like that. Our pain scores for the healthcare professionals listening, our pain scores are not 1 to 10 because it's not defined. It's not in a ratio. It can't be used like a chart, like any other patient, because what is painful to you may be not painful to me. Our pain thresholds are different. We are always conscious of our genotype and procreation, so don't say to us, oh, but you've got sickle cell disease, why do you want children? With modern technology, we can reduce the prevalence of sickle cell disease and the genotype formation. You choose who you love and then you work on that. And I think that's a healthy discussion that we all should be having, but not in a very judgmental way. We avoid hospital admissions and we know our body patterns. I always say to friends and family, give me the option to decline an invite. Don't assume because someone has sickle cell disease that they can't come out to a sports day or a church event or a wedding. Give us that option to decline, and to decline last minute as well, because it can be a very uncertain way that crisis occurs or an infection happens, or you don't feel like going somewhere. So give us that option and give us that right to refuse, or that right to say, can I come last minute? That is something that I'm very passionate about in terms of my friends and my support system. It's not that I don't want to come out or we don't want to come out or whatever. Give us that option. We are not drug seekers, nor are we lazy. We have good days as just as bad days, and sometimes we often have better days than the bad days. And also, we know our eyes are yellow or glassy, so please don't remind us of it. We look in the mirror, we see. This is just a context of people always saying, but you look pale and your eyes are glassy, or it's yellow, or this is the best I've seen your eyes and things. And that is because we are unwell. So don't tell us we know what's going on. And this is to the end of the talk. I am available to chat if you have any questions, if you need any support, any guidance in how best to manage a loved one, a friend, a co-worker. I am here, and keep calm and support sickle cell awareness, support the Sickle Cell Society UK, and look after each other, look after yourselves. Thank you for listening. My name is Amanda Joseph. I am a sickle cell warrior. I am a child of God.